Hello everyone, this is my lung ventilation demonstration. So first thing we are going to discuss is how the lung cavity, or the thoracic cavity, is a chamber for our lungs. The bottom of this chamber is the diaphragm, which when it relaxes, increases the lung pressure, decreases volume, and forces air out through our mouth and nose. And in the opposite direction, when the diaphragm contracts, it lowers the overall lung pressure, increases the volume, and forces air back in. So we'll see through this video with the syringe and balloon when the diaphragm moves down, it inflates the lungs, and back up, it deflates the lungs. And so when people aren't able to do this for themselves, we can do this for them with a BVM or a ventilator. And a few important things to keep in mind is using a normal tidal volume. A BVM is much larger than what a normal tidal volume needs. And so we need to be conscious of how hard we're squeezing that bag. We're going to watch their end tidal to ensure that everything's flowing the way that it's supposed to and that they're oxygenating and ventilating in the way that we want them to. And we're also going to use PEEP that helps keep those lower airways open where the gas exchange actually occurs. And so if we have poor quality ventilations, there's a few key pathological problems that we want to watch out for, being a pneumothorax, barotrauma, and narrowing pulse pressure. As the lungs inflate, they can put pressure on the heart, and it doesn't have the ability to expand and fill as it should. So first we can talk about hypoventilation. When we ventilate too infrequently, we're going to hold on to carbon dioxide, increasing our end tidal CO2, which is going to lead to acidosis. And if we ventilate too quickly, too frequently, we're going to blow off too much carbon dioxide and decrease the end tidal CO2, which leads to what's called a VQ mismatch, where we're giving the patient everything they need to ventilate and oxygenate, but they're not in the right matching conditions, and it doesn't work as efficiently as it should. So we can talk about one good example being chest puncture trauma, which generally leads to a pneumothorax, which first we will generally see as a wound that gives out a sucking, hissing sound and foaming around the edges. The patient will generally cough up some blood. It's going to lead to increasing thoracic pressure, eventually tracheal deviation, and hypotension. So we have this video where our syringe has a stab wound in the side, and we can see that no matter how hard or how fast the diaphragm moves up and down, the lungs do not inflate or deflate. And so the treatment for that, we're going to start with oxygen and fluids to maintain their blood pressure and their oxygenation. Then we can use a vented chest seal and needle decompression. In this video we have a chest seal. So we've plugged the stab hole in our syringe, and the diaphragm moves up and down and the lungs still inflate and deflate. And what's notable is that the syringe has to be pulled down much further than our original example to inflate the same amount. And so there's still air trapped inside of the chest. And so to drain that extra air, that's when we would use a needle decompressor and the vented chest seal. So that's going to let the air inside the chest and outside of the lungs leak out, but no more is going to be able to come in. Another intervention we can use is positive pressure ventilations like CPAP or BVM. That's going to put a lot of extra pressure inside the lungs and try to get them to inflate and refill that space and push out the extra air inside the chest cavity and outside the lungs. And then another important tool we're going to use is pain management. If someone's been stabbed, it's going to hurt to breathe. And so if we make them hurt less to breathe, they're going to breathe much better under their own power and be able to protect themselves much better. Thank you.